Okay. Good evening, everybody. Welcome to this this webinar rather, on prevention and managing parastomal hernias. Um, Quite appropriate day for it today because it's World Cancer Day today, 4th of February, which is an annual event. We have two or stroke three speakers for you this evening. Um, and we are recording the event, so it'll be put on the UA website. The sponsor for this evening's webinar is the hospital Saturday Fund. They've been kind enough to make funds available to us to carry out one or two webinars. So thank you very much indeed to them. So just a brief introduction on the speakers tonight. The first speaker is Mr. Mohammed Belal. Um, he's a consultant urologist at Queen Elizabeth Hospital in Birmingham, and also a trustee of the Urology Foundation. But one of the things I did find out on on searching on Mo was that he's very well known for his very good bedside manner. So I found that one out. So thanks, Mo, for spending time with us this evening, and look forward to your talk. The second one is going to be slightly different in that we've got Sarah Russell, who's Sarah again had problems back in 2010 with a perforated bowel and peritonitis set in, and she had a tough time in hospital getting that sorted out, and eventually ended up with an ileostomy, I believe. So Sarah is going to be talking with Gill Thomas. Gill is a fairly new urostomate. She is member of the Cambridge branch, and Jill used Sarah's expertise to help her with exercise to help prevent hernias occurring. So I'll hand over to Mo now, and we'll take it from there. Thanks, Mo.
I'm just going to share my. Thank you very much. It's an absolute pleasure to be invited to talk about reducing the risk and managing parastomal hernias. Thank you for the very kind introduction, Brian. It's a pleasure to come here and talk about this. And so the first thing is we've sort of got to define what is a hernia. Actually, a hernia is generally when something's out of its compartment. So the human body is in certain compartments. Now, the parastomal hernia, it's not really a peristomal hernia. Peristomal hernia would be coming inside the hernia. So it's actually a parastomal hernia, and that's a protrusion from the abdominal wall through that abdominal wall defect, which has been created by surgery. And so the difficulty is actually it's a very common complication after stoma formation. I'll quote there about 30 to 50%, but it can actually be up to 70%. And so why is this a problem? Obviously, it can lead to symptoms in terms of pain, discomfort. But more seriously, it can actually cause complications such as obstruction of the bowel or even strangulation of the bowel, which are both extremely serious. With people living with a lived experience, I don't need to tell you how much parastomal hernia can impact your quality of life and how you manage that stoma. And you all guys, most of you guys here are, living experts of stomas. So the way to sort of understand how parastomal hernias form is you've got to really see it in terms of two forms, really. One from patient-related factors and one from a surgical point of view as well. And one of the things I would say, in my experience, the BMI or high BMI is actually a very big related factor. And so certainly in my experience, if we're doing, for example, urostomy for benign conditions, we insist on a certain BMI. And so in our practice, we have a BMI of less than 35. And that's one because of a technical reason. You have to get the small bowel through a larger thickness. Obviously, in an emergency setting or for cancer, then you have to accept whatever the BMI is. The second thing is with increasing age, what we tend to find is that the healing is not as good. And so the older you are, you're more likely to get parastomal hernia. than a younger person generally, and that's a lot to do with the musculature um, as well as the healing property. Sort of conditions that actually make things worse are, for example, if you've got a chronic cough or anything that causes intra-abdominal pressure. And so, some people can have what's called bronchiectasis, where they have a persistent cough. And that persistent cough, what it does is increases the abdominal pressure, and that's what can lead to hernias. The second thing is that preceding your surgery, you've got a very weak core, and you may be suffering from poor nutrition, for example. So, with surgery is only a success if the patient is in good nutrition, um, and also what the pre-existing state was like. If you've done no exercises before, then unfortunately the musculature is going to be weak, and we as surgeons can tell as soon as we operate when we operate in terms of what that musculature looks like. The surgical factors tend to be more in terms of the stoma placement. Now, for example, if you place it through the rectus muscle, then you're more likely to get a parastomal hernia. Or if your defect, the difficulty is it has to be the right size, not too large, not too small. If it's too large, then you're more likely to get a hernia. And the other thing I've kind of mentioned is that if it happens during emergency surgery, or there's a technical failure from the surgical point of view. So I think the key strategy with all these things is about prevention. And one of the key things really is the optimal stoma placement. And so we normally have a specialist nurse actually place the stoma, and that is so important. Not only in the sitting and standing position, in all the different positions. And the times we see problems with the stomas is that that's not really been followed through, and it's either in the crease or it's not, it's in a particular area of weak musculature. Generally speaking, we tend not to use prophylactic mesh, but can be for redo surgery. You may all know that mesh is suspended for urinary stress incontinence surgery, and so there's an associated issue with mesh, but we'll come on to that later. And so you've got to ensure that the stoma passes through just the right amount. And one of the sort of that from the surgical point of view, there's lots of different ways you can, improve your technique, but I think that's probably less relevant in today's talk. So in terms of post-operative care, this is probably one of the most important things really, is managing the expectation of people going through surgery. Sadly, everyone thinks that the surgery is almost instantaneous, the effects are almost instantaneous, and that's not the case. And one of the key things is avoiding heavy lifting or strenuous activity during recovery. And so we're talking about at least 6 to 8 weeks in reality. The healing process, the way to look at it is if you cut yourself, it doesn't heal instantaneously, it takes time. And that's just a simple cut. And so, and it's amazing how many number of people actually do things like moving house after they've had an operation, and it never ceases to amaze me. The second thing is really about managing your chronic conditions. It's likely after surgery people will get constipated. It's really important to manage the constipation or the chronic cough that you may have. The constipation more so because it affects more people. And so most surgery will involve opioid medication, which means that your transit time will be reduced. And therefore, it's really important that you maintain a high fluid intake, and you may need laxatives during that period. Otherwise, with constipation, people are straining, and that's what is a problem. The other thing post-operative is really important is weight management, and ideally, I would suggest that your core strengthening exercises, if it's done in an elective fashion, should be done prior to that. And weight management is probably one of the most important factors to maintain your weight. So what happens if you do get it? You may notice a visible bulge around the stoma. You may have pain around the stoma, and you may have difficulty fitting the stoma. And actually, you might notice that the stoma function is different. And for example, there's less coming out, maybe positional. And with these sort of things, the only way you really know is obviously, you can examine as a clinician, but actually imaging is going to give you the answer. In the old days, we did a lot more ultrasound, which is a non-invasive therapy in terms of looking for hernias. But actually, a CT scan, even a plain abdominal CT scan without intravenous contrast, is actually really useful in terms of knowing exactly what sort of hernia it is. But the thing is, you wouldn't reach that stage until you've got significant symptoms. So for most people, actually, most of his supportive measures, you may require a sport belt or a hernia support garment. There's a whole bunch of different supportive measures available. You can, with the help of the stoma nurses, you can have adjustments to your stoma appliance to get a better fit. Now, if, for example, you put on considerable weight, now there's no reason why you can't lose weight. You've got the GLP agonists and GLP-1 agonists like Zempic or Manjara, which are very effective in terms of weight loss. And obviously, you can avoid doing the heavy lifting and in terms of your constipation to ensure that you're not straining. So I think if you recognize it early on, you can be preemptive in terms of preventing progression. And obviously, it's important to sort of follow up with your local stoma nurse, and if you do need surgical intervention, to do so. So what would we do in terms of when would we operate? Well, actually, if the person is very symptomatic of the hernia, for example, they've got a lot of pain, there's issues with drainage that feels obstructed, or they may have other bowel symptoms too. And for example, there may be a nubbing of bowel in that hernia, which can twist. And so surgery, I think the indications for surgery generally tend to be, it's all about risk and benefit really. And the risks, with any form of surgery can be significant. But actually it's the benefits. And so if there's a small hernia, which you can deal with in terms of supporting measures, then you're better off holding fire. So what do we do when it comes to surgery? One of the first things you can do is use the tissue around and use that to repair. But if the tissue itself is weak, actually, the problem with that generally is that there's a higher reoccurrence rate. And so that means that the tissue itself is weak. Even if you tighten that tissue up, it's liable to fail. So with primary repair, there tend to be a high failure rate. And so it may be possible for a very small symptomatic one. The second one is really you need to support it with something else. And so it's either going to be synthetic or biological mesh. So synthetic mesh tends to be cheaper, biological mesh tends to be much more expensive. And there's different ways you can do it, either with keyhole, you can do it on the inside, and then you can do it on the outside, or you can do a combination of both those two. So generally speaking, I think the synthetic mesh may be used in the first instance, but then the biological mesh may be used if it's a further complex hernia. The other option is to change the hernia location. And again, that can occur with complex and recurrent hernias. And sometimes you change it from the right to the left, or you may change it up or down. But that's not without risk itself. And then the other sort of considerations are really with any operation, there's risk involved. And so generally speaking, your first repair tends to be the best. But generally speaking, I'd say that actually in terms of urostomies, I would say the overall outcome is probably different in my sort of opinion than say for ileostomies, because if you imagine it's urine that's been collected, which is slightly different. The bowel's actually organized for feces. And so in order to get the feces out, you have to generate higher pressure. Whereas with liquid, because of the capillary effect, it tends not to be the case. So I think the key thing really, to take home from this is really the importance of early reporting of your symptoms, the importance of adhering to postoperative care, and actually about reducing your lifestyle changes to prevent risk. And the biggest risk really is constipation and weight loss. And I think one of the other important things is having resources, for example, like the Urostomy Association, which can support the patients through this, have education materials on the stomas, and then we'll hear later on how to improve your core to prevent future complications. And so In conclusion, I'd say that, look, parastomal hernias are common, but they're a manageable complication. A lot of it's about prevention or preventing it from deteriorating. And the key thing is really about patient education. I think once you find it, it's really important to manage it early on, ensure there's no further weight loss. I think it's really important that when people do have parastomal hernias, that you involve the right people, which includes the surgeons, the stoma nurses. And I think the future will be bright as technology improves. There's new biological meshes which will allow and ensure that actually there's a reduction in parastomal hernias. Thank you very much.
Thanks, Mo. Thanks, Mo. That's all very interesting stuff and perfect timing. You're spot on with your timing. One thing I forgot to mention at the beginning, everybody, is if you've got any questions for any of the speakers, if you could put them in the chat and we'll take them at the end. So put them in there and then we'll pick them up and we'll address them at the end of the session. So if I can hand over now to Sarah and Gill.
Thanks, Brian. Shall I kick off, Sarah?
Yeah, sure.
Yeah. So, I mean, just to say a couple of words about myself and why I'm on here tonight. So, I had my surgery 7 months ago. So, I had a urostomy. Before that, I was physically active. I ran, I did yoga, I went to a gym. And I was really concerned. I mean, I think there's quite a lot of scare stories. I found your presentation, Mo, quite reassuring because I'd got myself really quite nervous about what was out there on the internet about the risk of developing a hernia. And nobody really talked to me about it at the hospital. So when I was about 4 weeks post-op, feeling a bit more sort of human, I Googled yoga and stomas. Nothing came up around that, but the Ostomy Studio came up. And for me, that was just fantastic as a whole program from post-op right the way to advanced of strengthening your core. And it felt incredibly safe, Sarah's approach. But then come December, I'd sort of got to the advanced stage. I wanted to start running again. I wanted to go back to the gym, but I felt really quite nervous about it. So Sarah and I ended up having an hour conversation where I ran through all my anxieties, which was so helpful. And we thought tonight it might be quite helpful to do something quite similar in a broader sense, not about me, but about, going through that journey sort of more generally. So Sarah, kicking off and going back to sort of the beginning of post-op and when you're starting out in your physical recovery, could you talk through how abdominal training minimizes the risk of developing a hernia for anyone who's had a stoma?
Right. Hi. Thank you for inviting me, first of all. It's really lovely to be here. Thank you. It's great to talk to you all. Okay, so what was really interesting was in Mo's presentation was very aligned to my thinking around, as a patient, as an individual, with somebody who's living with a stoma, what can we do as individuals to help reduce the risk? I don't tend to use the word prevent, but I tend to talk about risk prevention, reducing the risk and also managing a hernia from potentially getting problematic or much bigger. And in Mo's presentation, you talk very much about the abdominal wall and the muscles. It's a little bit more than that. We need to think about the body a little bit more holistically as a whole, because we need to have strength through our arms and legs in order to move with really good function. But if we think about, one of the things we're doing at the moment is writing some international guidelines on exercising and kind of just around hernia management, around stoma surgery. One of the things we really need to focus on is what we can do pre-surgery. So we can learn the correct breathing techniques, we can learn the correct exercises that we need to be doing immediately post-surgery. If we can get the muscles a bit stronger pre-surgery, great. If we've only got a few days, we can still learn how to breathe correctly so we can manage intra-abdominal pressure. And then coming to post-surgery, the Urostomy Association current guidelines recommend that we start some very gentle core exercises at around about the 3 to 5 day mark Now, that might sound really shocking, but we're not talking about doing sit-ups in hospital bed. We're talking about doing breathing exercises and some kind of engaging with the core. So we need to start sort of think of it like neuromuscular retraining, but in the brain to kind of reconnect with those deep core muscles again. So that helps to manage our pressure. I'm not sure I answered that question really, but anyway.
And so, for someone who maybe has had their operation quite some time ago and wants to start now developing, their core, what sort of advice would you give them?
So I start at the same point with everybody. I make no assumptions. So even if somebody is 10 years down the line, 20 years down the line, I will never assume that they've retrained that ability of their brain to connect with those deep core muscles again. So the first thing I do with everybody is go through a process of kind of breathing and of really kind of working those deep cores. So can you find your deep core muscles? Can you engage them? Can you pull them in? And can you do that with the correct way of breathing? So that would be the starting point really for everybody. And unless people can get that right, which is really around managing your intra-abdominal pressure, we don't really want to move on too much further. So I would start at the same point with everybody. So you're starting kind of like learning the techniques, whether you're post-surgery days or 10 years down the line. Now, obviously, if someone's 10 years down the line, they're going to progress a little bit quicker. But we always start with that. Can you breathe correctly? Are you engaging with your core correctly? And then we start there.
That's fantastic. And if somebody feels that they might have a hernia or they know that they have got one, is there a different approach to exercise? Should they be avoiding it, or should they be very much doing the same kind of thing as you're talking about here?
Yeah, I'd say we definitely don't want to be avoiding exercise and movement because it's so important for our health. So, we know that physical activity in general, certainly in terms of the links with cancer recurrence or development of other cancers, you're looking at a significant improvement of reducing your risk of cancer if you can be more physically active. Now, that's not saying you can prevent cancer by exercising, but there is a definite link between physical activity and reducing that risk of cancer. So, we've got diabetes, other comorbidities, other conditions. We need to think about the person as a whole and not just about the stoma and the hernia. And so physical activity has a really important part to play. So I would say definitely don't be less active. We do know that happens, though, from the research. But try and find a way to be physically active alongside your stoma and your hernia and to find ways to manage it. But that core strength and that core function has to be the foundations of the house before you can do anything else, really, so that you're moving safely and you're moving with that kind of braced core, if you like, which provides that internal support garment and sort of like the muscles are working correctly.
Really helpful. And then one of the things that we talked about, and there's a lot out there on kind of blogs and Facebook posts, and Mo touched on it, around support garments. So I'd sort of got in my mind for myself that I shouldn't start running again until I'd been measured and fitted with, a support band. But once that came, I found it incredibly restricting to do anything in. And also I was having the problems, it was making me really sweat under my bag, and I was then starting to get a skin problem. And so, and then, you and I did talk about actually whether one should wear a support belt for exercising. It might be quite helpful if you could talk a bit about what we talked about last month.
Sure. So this is a bit of a soapbox topic for me. So the support garment question is quite an interesting and slightly controversial one. We are just doing a big literature review at the moment for our guidelines that we are writing for the Association of Stoma Care Nurses. So we're writing a project. So as part of that, we're reviewing the literature. And in the literature, we're looking at support garments. Do they help with hernias? What's the place and what's the position and narrative around them? there are many, many different types of garments, everything from a tight pair of normal knickers you buy in Marks and Spencer's through to a very restrictive, professionally fitted hernia belt. And there are hundreds of different products in that kind of category, you know. So the first thing to remember is that wearing a support belt has not been proven in the literature to prevent hernias. We know that through the evidence. That's not to say that a support garment doesn't have a place if you feel it's helping you and it provides you with some comfort. Now, if you have quite a sizable hernia or a hernia which is uncomfortable, you feel you need support, that is slightly different. And a hernia support may be appropriate for you in that case. But we need to step away from this narrative of we have to wear a support belt at all times if we're doing something strenuous, because actually what we need to be doing is getting our core muscles working correctly so that we can, our muscles are working in the right way, if it's day or night, whether we move, lift, cough, sneeze, laugh, push, pull, whatever it is. If we're not wearing a support garment at that moment in time, we can't be scared of something happening. So wear a support garment or some sort of supportive garment. It doesn't have to be a specific stoma product if it helps you and if you feel it gives you confidence and support. Do not wear one if you feel you should, because you think it's going to prevent you from getting a hernia. If something is very restrictive and it makes your bag leak, it makes you sweaty, it's uncomfortable, it's affecting the way in which you breathe, that's probably not the right garment for you. And you need to find something that is either more comfortable or maybe try without. Now, I know, Gill, how you've done your exercises. I know how you've progressed up to an advanced level. You went into your surgery at quite a high fitness level, so you were coming in at a good place. You started training again quite quickly. You've progressed quite quickly, and now you're at a really good place again, and quite an advanced level. So for you, heading back out to go running without wearing a support garment at all is absolutely fine. And I wouldn't have a concern about that at all. But it's really about getting these core muscles, the pelvic floor, the diaphragm, the core, everything working correctly and functionally. So we're managing our pressure so that we can then strengthen those muscles safely. So yeah, I think, yeah, hopefully I've answered that question. There was a few other questions popping in as I could see about support garments. So I think that's probably my stand on it. Different professions will have slightly different approaches, but I feel it's really down to the individual person to decide what feels right for you. If something's very restrictive, it's not going to be a good thing because it's going to affect the way you breathe. And actually, the way you breathe is really important for how you manage your pressure. So imagine a balloon, and when you squish the middle of the balloon, what happens to the top and the bottom? It kind of bulges. So you're just pushing the pressure somewhere else, and that's not going to be a good thing. So we don't want to do that.
So I think just maybe one more question and then open it up, because a lot have been coming in to the chat. So as in my position, I've strengthened my core, I'm back out running, not to where I was, but I'm building myself up, I'm starting to do yoga again. Can I now assume that my abdominal strength is back to where it was pre-op? Or do I need to always be careful?
So I'll just pick up on a couple of things there. First of all, I'm going to pick up on the word careful. I like to use the word mindful rather than careful, because I think when we start feeling like we need to be careful or cautious, we start to feel quite fearful about movement and exercising. And for me, that's not a good thing. I've got exercise running through my blood. I think it's, everybody should be doing some form of physical activity for health. So I think we just need to change our mindset around that. So do you need to be mindful? We don't have any studies yet, but I've worked with thousands of individuals with stomas all around the world, and I've trained hundreds of nurses all around the world. My view is when we've had stoma surgery, we need our abdominal muscles and our core function to be better than it was before to do the same thing. That makes sense? So if we wanted to run a marathon before, we might have gotten away without any problems if our core wasn't really that great. I know loads of marathon runners with rubbish cores, they get away with it. If you put a stoma on that person, you put a hole in the abdominal wall, that abdominal wall has to be stronger to tolerate the same load and the same thing that you're going to ask of it than you did before. So I think, yes, it has to become a lifelong thing. And I think we have to keep working at it. We can't just do a few pelvic tilts, a few knee rolls in the hospital bed and think we're done and we've ticked our core rehab box. I think we need to do a little bit more than that. And if we want to do things like gardening and quite strenuous DIY, or even playing with our grandchildren or picking up children, that places quite a lot of load on the abdominal wall. We need to be strengthening the core to enable us to do those things safely.
And just one follow-up on that, which is a difficult question, this one, Sarah, and one that, and how do we know that the abdominal core is strong enough to do what we want to do? I know that's not a perfect science to answer that, but that's something you and I have talked a bit about, and that I have struggled with about, how do I really know that it is safe for me to, or it's minimal risk for me to now ramp up what I'm doing?
Yeah, I don't think there will ever be some kind of test where we can say, right, you can do 10 reps of this, now you can go for a run. I don't think it's that straightforward. It's so much more complex than that, because it's around our alignment, it's around the way in which we breathe, we use our core muscles. I think it needs to boil down to, have you worked through the relevant stages of rehabilitation and recovery with regards to your abdominals and pelvic floor muscles? Have you got through to the point of doing to intermediate level or as high through the program as you can? And it needs to become quite intuitive. So I think if you feel vulnerable in your body when you go and try an exercise or a movement, then you're probably right to trust that vulnerability. Maybe you're not quite strong enough to do that yet, so you need to work a little bit harder. We've come back to some exercises and then progress back and try that thing again. I'll give you a slightly out there example just from myself. So prior to my surgery, I was a marathon runner, I was doing cycling, all sorts of different things, doing triathlons, etc. Had my surgery, got back into doing marathon running a few years later. And when I first ran my first marathon, I felt really quite bulgy around my stoma. So if I run a 10K, probably all right. But to take it to the length of a marathon, which was, 4 hours, 5 hours on a trail, quite hard going, my stoma felt quite bulgy by the end. It wasn't a good feeling. Now, it wasn't a full-blown hernia, but the muscles around that area were not tolerating the load very well. So I've done a lot more core training now. I do Pilates 3 times a week, if not more. I can go and run an ultra now, which is much further distance, and I don't get that same feeling of bulging. So it's almost like the strength of the muscles need to kind of come up in line with the requirement of what you're asking. There's not going to be a test. It's going to be a bit more of an intuitive feeling. And you need to kind of be really honest with yourself and kind of look for signs like a bulging, extra bulging around the stoma, or any symptoms that you might be getting. So any kind of change in output, or any kind of symptoms where you might get the stoma not working very well and then a gushing out later. And symptoms like that might be a sign that you've either overdone some exercise or you need to strengthen up a little bit more. So it's kind of, I guess, just looking for some really simple symptoms, and just that sensation of vulnerability and feeling like you kind of nailing it is kind of, I guess. So I'll ask you a question then. So you got back into your running after we had that conversation. Do you feel vulnerable, or do you feel secure enough through your abdominals?
Yeah, I really do feel secure enough. I'm absolutely loving it. I'm not up to where I was, and I'll never be an ultra runner, but I'm just being outside, being able to run. And if anything, it's now my legs keeping up with my abdomen rather than the other way around.
So, I mean, that's the other thing as well, is when you're coming back to it, you need to just go back at it like a beginner, because your risk of running injury increases, never mind your any sort of risk around your stoma. But I think it's around building your strength, thinking about that core as your foundation, and the foundations for your house. And you probably could have gone back to running sooner. So yeah, there's loads of questions come in. So
I think I'll hand back over to Brian to deal with those. Thank you, Sarah.
Thanks, Jill.
Yeah, thank you, Sarah, and thank you, Jill, for that very, very interesting exchange there. That was really good. We've had a few questions come in.
The questions are all kind of in the open chat. So Ruth says, I've got 2 grandchildren, age 1, and are they twins? And have avoided picking them up since surgery due to concerns about heavy lifting. Do you think I can get to a point where I can pick a toddler up, put them in a swing, or lift them out in and out of the car? So picking up a heavy child and putting it into a car, or twisting or getting them into a swing, is actually quite a challenging movement for the core. When we are taking a heavy load and we're taking it away from the body, that increases the loading on the core. So in order to do that, you do need to have developed some strength through your abdominals, and to make sure that you can kind of almost do a little bit of bracing through the abdominals whilst you're lifting and picking them up. That would be something you'd need to learn, we'd need to work through in some classes, and kind of, get that good connection with those core muscles. Yes, you probably can get to that point. And it may be that you get the child to support themselves a little bit as well. So it might be that, they can climb halfway into the car, and then you can sort of push them up the rest of the way. There's ways to kind of modify the way in which you lift things. The issue is everyone's so scared about lifting. So we need to get the abdominals strong enough and the core strong enough so you can lift safely, but you need to be able to lift and maybe slightly modify some of the movements. If it's a child, get the child to kind of help you a little bit, if they can get a leg on or something like that. And try and keep them close to your body as possible. So rather than like holding them out, it's all quite awkward getting them in cars and into swings and things. Right, I'm just going to wrap through these questions, and then we can kind of...
Sorry, I'll just add on to Ruth's question. It really also depends on how soon after the surgery.
Of course,
as well.
Yeah.
So what I would say is that actually, if it's early on, within 3 months, then it's probably best avoided.
Yeah.
So again, it kind of depends on what your pre-existing status was. So, if you had a lot of strength, you did lots of strength exercises beforehand, then it's slightly different than having never done any strengthening exercises. And so it kind of really depends on where you were before, and that's your baseline. And so generally speaking, you've got to sort of factor that in. So if you did lots of exercises, a lot of strength exercises before, then it's actually not, you just, like Sarah says, you need some modification. And as Brian says, as they get older, it becomes increasingly difficult. And so at some point you have to decide that, look, they're just too heavy to lift. That's my comment on that one.
Yeah, no, I agree. So in the bit that is also about at what point you are post-surgery as well. And I would say that, using some kind of weights, so say you're doing some weight training with some weights at home, using some stretchy bands to improve your resistance, to improve your muscle strength. Doing things like that can help you. We should all be doing that as we get older anyway, regardless of whether we've had abdominal surgery, to maintain muscle mass and maintain muscle strength. So those things can help you as you age, and they can aid your ability to lift things more safely. And also, if the child is really heavy, they can probably climb in the car themselves. They're probably at an age where they can maybe do that. Right, let me rattle on through some more of these. Have any trials been done to show the results of core exercises and stoma belts? No. Not as far as I know. There's been lots of trials, well, not lots. We've just done this big research study, and we found like 83 papers ever, which is nothing. So you know, the trials that have been done have been very, very small, very, very on very low numbers of people. And there's not really been anything found in terms of effectiveness of exercises or stoma belts. There've been a few. There's some a Danish researcher did some work. We did a small trial here called HALT, which was the hernia active living trial. So you could look that up if you wanted to find that. That was done with a university in Scotland. And what we found with that trial, we gave people with significant hernias, we gave them some core exercises to do, and they we're not making the hernias go away, but we are providing some strength and control to the abdominal walls. They definitely felt better, and they felt in some cases the hernia was slightly smaller. So there's definitely some little bits and pieces coming through, but not really any good trials.
My comment on that one is the problem is there's so many different stoma belts, and so you have levels of evidence. So the level of evidence would be very poor because there's too much variation, and also and that's why there's degrees of hernias. There's complex hernias, there's recurrent hernias, and so actually that's why it's unlikely that you're going to get any decent information. But what you can say, as Sarah said, is that intuitively, you know, if you are going to improve your core, that is going to help. But whether or not avoid surgery, probably not so if it's a large hernia. You will invariably will need to, you know, the core exercises will only reach a certain point.
Okay, so David says, I've put on nearly 3 stones. It's my urostomy operation in 2019. Although I was advised against weight gain, should I try to lose weight? I'm now 15 stone 4. As Mo was talking earlier, I had that same conversation with a colorectal surgeon a few months ago, and we were talking about the potential use of weight loss drugs like Ozempic in situations like this, where really weight loss should be a priority, or weight management should be a priority. Now, whether that's appropriate for each individual is a conversation to have with your own doctors. My only concern around that approach is the loss of muscle. So if you were to go down that route, you would need to be looking at, you know, making sure that you did some resistance exercise and some core exercises to try and maintain as much muscle mass as possible. And obviously, if you can lose weight without using weight loss drugs and maintain muscle mass, then that would also be a good way to try and do it. But, you know, sort of any kind of weight around the tummy is not good news for hernias. So we need to try and, you know, stay as lean as we can around the tummy area, really. Yeah, because it makes it difficult for the surgeons to do the surgery in the first place, but it also kind of creates almost like a chronic intra-abdominal pressure, particularly if we have a lot of what's called visceral fat, which is on the inside of the body, rather than just the layer of fat under the skin.
My comments would be a bit what Sarah said. Actually, Mounjaro, Ozempic have been a game changer. You do have to try and maintain that muscle. The problem is 3 stones quite light. It all depends on your height. If you know, 3 stone is what, almost 18 kilograms, and so I think even if you go on those injections, it would be beneficial for you. Or weight loss. The only thing to do say about significant weight loss is that you can get skin creases, and that can cause a problem with your stoma application if you lose too much weight. And I must say, most people wouldn't lose that much weight, in my experience. The second thing is as a man, what happens is your testosterone goes down as well, and so sometimes it's actually hormonal changes like the male menopause, really, and so sometimes it's useful to know, is this weight gain due to your thyroid? So you might need your thyroid function test, you might need your testosterone checked, and those are the things that might be useful. So, for example, if you become hyperthyroid, then weight gain is much easier. So I would suggest that maybe it's worth going to see your primary care physician to at least have a baseline test of your thyroid function test or even your testosterone. And if there's a significant issue there, then that actually might help. So if you get your thyroid function, if you've got hypothyroidism, then thyroxine can help. So, you know, I think, David, you should make that priority, that should be your plan in 2025 to lose some weight.
And just on the hormone aspect there, in terms of females as well, I think I'm now of a certain age where I'm into menopause, and as females age, the loss of estrogen affects our muscle mass and soft tissue and fascia, and so I found that my stoma is definitely more bulgy. I've got a very small parastomal hernia, and it's been really stable for 15 years, and now I'm heading into menopause. It's not as stable as it was. I can feel it getting a little bit bigger. And so I think, I've started HRT, and that's, I'm hoping, going to help. But it's, again, I think it's a very big picture. It's not just one thing. We need to think about the body as a whole and all the different systems around the body. Okay, so John says, I hope that somehow the different urological departments need to advise suitable exercises, such as Sarah advises. So I challenge the UA to expand this info to those departments. That would be great. And I think as we get the, it's one part of the picture, but it's also a really important part. As we get these international recommendations, the best practice recommendations written and published by the end of this year, hopefully that will start to happen. It will filter through. The Association of Stoma Care Nurses already have in their guidelines that people should be advised to start some kind of core retraining exercises within 3 to 5 days post-op. So that has been there since 2016. We need to really push the stoma nurses and push just generally to kind of bring this into good practice.
To Brian and Samantha, I think it's worthwhile liaising with BAUS. I'm also a member, I'm the vice president for education in BAUS, in terms of liaising with that, in terms of, I think that there are two sort of separate differences. The urology department and the general surgery department are actually very different. And so actually it's probably worth it, Urostomy, liaising with us, and we can put on our website for the urologist and for the patients a pre-stoma type information, and so or can certainly signpost to that. So Brian and Samantha, perhaps outside this meeting, we can liaise and ensure that at least we can expand this information so it's readily available to the patients and obviously to the urologist as well.
Thank you.
Okay, I'm going to crack this because we've got 9 minutes and there's lots and lots of questions. Someone's asking, could we be provided with the breathing techniques and exercises? I would love to teach this to you now, but we definitely don't have time for that. Please do contact me though. Get my details from Samantha and I will signpost you to some resources. So Madeline says, I found stoma support simply flatten the pouch and don't provide support from underneath. I've researched all manufacturers and there is nothing for under hernia support or under the bag support. So, as Mo was saying, there are many, many, many different types of garments with different types of strength, different types of, so if you've tried everything, I do know that some people, and this is not a researched or necessarily a technique that I've seen recommended, but I do know that some people use kinesiology tape, just like a sports tape, to sort of support the hernia. That probably wouldn't work on maybe quite fragile skin, but it might be something to talk to your stoma nurse about, which is potentially an option. And you can kind of get that right around the stoma bag and then put something else on top. Okay, would I regard swimming as a beneficial exercise for someone with a hernia? Yes, most definitely. The pressure of the water is really good. So I would definitely say so. Yes. I'm 6 months post-op and did Pilates before surgery. Started Sarah's program, but I suffer an awful lot with the pulling and dragging feeling from my bag. Will that abate with a more strength and core? Okay, it's hard to answer that because I'm not quite sure what you mean, and I'd need a little bit more information. I'm assuming it's the weight of your bag that's pulling, or it might be scar tissue in your abdominal wall that you're referring to. So yeah, I need a bit more information on that, Fiona. So drop me a message and we can have a chat about it. How can we access my program? So I'm absolutely not here to try and Sal, I'm just here to try and help support and provide some information, but I do have a website called the Urostomy Studio, and on there I've got a series of videos you can follow that start at around about 10 days to 2 weeks post-surgery. You can get onto the floor and you can do them in bed as well, and then progress all the way through up to advanced level. I also wrote the Me Plus Recovery program for Convatec, and that is free of charge and available on the Convatec's website. So that is something that you can access. It has very, very similar exercises in it. Okay. John says, I joined Sarah during lockdown, but had problems interpreting the exercises she suggested. Doing it online from the computer, it's a man thing. I don't think it is, John. It's a very hard thing to try and do. I had problems thinking about Pilates being suitable for man. I'm totally converted, having seen where Dr. Pilates did work during the war with Italian prisoners. So now I go to instructor in town. Okay, great, good stuff. Very pleased to hear it. I definitely think Pilates is clinical Pilates, not just any old Pilates, but clinical Pilates is incredibly important because it teaches us that mind-body connection, and it helps us re-establish that neurological and sort of neuromuscular pathway that we need in terms of retraining our core. Bruce says, I'm 7 months on, I'm relatively young at 54, but didn't have particularly strong core before, so we'll start working on it now. Awesome, good. Don't go crazy. You need to go in step-by-step way. Start absolutely post-surgery beginner stuff. Learn how to engage with those core muscles. Start with pelvic tilts, bridges, really, really easy stuff. Don't try and run before you can walk. Nail the techniques before you progress. Chris says, I'm 8 weeks post-ileostomy. Ileostomy? Okay. I was what could be described as a tactical athlete beforehand and an outward bounds kind of person, climbing, canoeing, etc. I'm hearing there are people spending years before re-engaging with serious running race. I intend to go back into my operation role, maybe more as an instructor. However, I'm now getting the feeling this is unlikely. At 58, I feel I need to keep my previous activity as long as possible. Thoughts? Drop me a message and we can have a chat. Let's just say I'm often described as not being a typical patient. I had 5 surgeries, 3 ileostomy surgeries, reversal, put back, blah, 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 lots of complications within an 18-month period. And I was back climbing a mountain by around about 9-10 weeks post-op after one of my surgeries. And I now, well, I'm 15 years post-surgery now, but I do adventure racing, kayaking, mountain biking, ultra running, all sorts of things. At 58, you are young. So let's get you back at it. Drop me a message and I will help you. Okay, Alex says, Samantha, can you put these links on the IA site for the recording? And Scott's just linked up to my website. Thank you, Scott. I appreciate that. Great. I think there's 4 minutes left. I'll be quiet. And unless anyone else has got more questions or follow up from any of that.
Thanks. Have you anything further to add, Mo, to anything that Sarah said?
No, I think I've added all the stuff I needed to say. But
okay, thanks. No. Well, if no, anybody, any last questions? We've got a couple of minutes left. If not, I'd like to thank Mo, Sarah, and Gill in particular for their input this evening. I hope it's been useful to everybody. As you exit the Zoom, there is an evaluation form, if you wouldn't mind filling that out, because it does help us with how we've done and what we can improve for next time. So please do fill that in. And thanks again to the Hospital Saturday Fund for sponsoring this evening's event. And hopefully the recording will be on the website fairly quickly. And there is a blog on hernias on our website as well. So please do take a look at that. And also Sarah's website to see what she can do to help you. So thanks, everybody, and hope to see you again next time. Thanks very much indeed. Good night. Stay safe.
Thank you.